All right, so you want to be an orthopedic surgeon, huh? Well, you've come to the right place. Welcome to the deep dive.
Hmm.
We're going to help you get through those tough postgraduate exams, especially those FRCS exams.
Yeah, they're not easy.
No, they're not. And to help us with that, we're going to be taking a deep dive today into the Ortho Made Simple notes.
Okay.
Now, these notes are from mokyingren.sg, and they're put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital over in Singapore.
It's familiar.
Yeah, and he aced his FRCS back in 2022. So we're hoping that some of that magic will rub off on us.
Hope so.
Now today, we're going to be talking about surgical approaches to the shoulder. So I want you to picture yourself there in the OR, scalpel in hand,
Okay.
ready to go. We'll be talking about 5 key approaches. The anterior deltopectoral, the deltoid split, also known as the McKenzie approach. We'll be talking about the posterior Judat, shoulder arthroscopy, and the clavicle anterior approach. So let's jump right in.
Sounds good.
First up, the anterior deltopectoral approach.
Yeah.
All right, so what's the big deal about this internervous plane between the axillary and the lateral pectoral nerves?
Well, you're trying to get to the shoulder joint, right?
Right.
But you've got all these nerves and blood vessels kind of in the way, so you're trying to find a safe passage, kind of avoid all those important structures.
Gotcha. So what happens if you hit one of those, like if you wander off the path a little bit? What are you at risk for?
Oh, you can get into a lot of trouble.
Really?
The musculocutaneous nerve, axillary nerve, anterior humeral circumflex artery,
Wow.
even the brachial plexus.
Okay, high stakes.
Yeah, so you got to be careful.
And what about patient positioning? I mean, you got to get this right to even start right.
Yeah, you're right. For this approach, we like to use the beach chair position.
Okay.
Gives you good exposure to the shoulder joint.
Okay, I see.
But you have to watch out. Sometimes the patients slide down a little bit,
Oh, especially?
especially if they're a bit on the larger side.
Yeah. That makes sense. Yeah. So as you're going in and making your incision, what are some of the landmarks you're looking for?
Well, first you want to start at the coracoid process and go down along that deltopectoral groove.
Right.
And then as you're dissecting down, you want to keep a lookout for what we call the three sisters.
The 3 sisters.
Yeah, the three sisters. That's the anterior humeral circumflex artery and the 2 vena comitantses that go along with it.
Okay.
And they kind of run along the lower border of the subscapularis muscle.
Why is that so important?
Well, the lower border of the subscapularis makes up the upper border of that quadrilateral space.
Okay, yeah.
And in that quadrilateral space, that's where your axillary nerve is.
Oh, so those 3 sisters are like a warning sign. Like, hey, be careful. Axillary nerve is nearby.
Exactly. Yeah, they're kind of like a landmark to tell you that you're getting close to the danger zone.
I like that, the 3 sisters. I'm going to remember that.
Oh.
Okay, so speaking of danger zones, how do we protect the musculocutaneous nerve during all this? Because you really don't want to injure that one, right?
Right. So you want to avoid retracting too far medially. And when you get down to the subscapularis, you want to make sure to externally rotate and adduct the arm before you go cutting into it. That moves the brachial plexus out of the way.
Oh, very clever. Very clever. Okay, so how about getting to the joint itself?
So once you've found all those landmarks, made sure that you're protecting all the important structures, you can incise the subscapularis tendon, and that opens up the shoulder joint.
Gotcha. Now, I've heard that you can sometimes extend this approach to get access to the humerus as well. Is that right?
Yeah, that's right. You can go anterolateral or anterior to get to the humerus, but we're just focusing on the deltopectoral approach itself today.
Perfect. Perfect. Now, this wouldn't be a deep dive without a little quiz, right? So let's imagine you're in the OR, you're doing this anterior deltopectoral approach. When would you ever consider doing a coracoid osteotomy?
Ooh, that's a good question.
Yeah.
Well, sometimes if you need a bit more exposure, maybe if you've got a complex fracture or if it's a revision procedure.
Okay.
And the key is to make sure you drill and tap the coracoid before you make the cut. That way you avoid any nasty surprises.
Now, doesn't cutting through the coracoid weaken the shoulder? What about all the things that attach to it?
Yeah, that's a good point. It does have a lot of attachments.
Yeah.
You've got your pec minor, your coracobrachialis, the short head of the biceps, and then the ligaments.
Wow, it's a busy intersection there.
Yeah, it is. You got the coracoclavicular, coracohumeral, coracoacromial, and transverse scapular ligaments.
Right, so you got to be really careful.
Yeah, it's definitely a calculated risk.
Yeah.
You have to weigh the benefits against the potential downsides. But if you do it right, with good technique, you can avoid any long-term problems.
Okay, so it's not something to be taken lightly.
Definitely not.
Now imagine you're in the middle of the surgery and all of a sudden there's a lot of bleeding. What's your first thought?
Oh, profuse bleeding.
Yeah.
That's not good. That usually means you've hit the anterior circumflex artery.
Okay.
So you got to stay calm, extend your approach proximally, and get control of the bleeding.
So stay calm and get control. Good advice. Good advice. Now, one more thing before we move on.
Okay.
The OrthoMade Simple notes mention that the musculocutaneous nerve enters the coracobrachialis muscle about 5 to 8 centimeters away from the coracoid. Why is that distance so important?
Oh, because you might be working in that area during the surgery?
Oh, I see.
Yeah, and you don't want to damage that nerve. So knowing where it enters helps you stay clear.
Right, avoid any lasting damage.
Exactly.
Okay, great. So that wraps up the anterior delta pectoral approach. Remember, we're going over the OrthoMade Simple notes from mokyingren.sg.
Yeah, they're great notes.
Really helpful.
Super helpful. Welcome back. So last time we were talking about the anterior delta pectoral approach.
Right, we dove deep into the anatomy, all those tricky landmarks.
Now let's move on to the deltoid split, which is also called the McKenzie approach.
Okay, so what are the key differences between these two? Like, what are the big things to watch out for?
Well, with the deltoid split, our main concern is the axillary nerve.
Oh, that's a big one.
Yeah, it runs right through the area where we're working.
So how do you avoid hitting it?
Okay, so we make an incision about 5 centimeters long, starting at the tip of the acromion and going down the arm.
Okay.
And then we split the deltoid muscle. But here's the key. You never want to split it more than 5 centimeters.
Why is that?
Because if you go further, you're right on top of that axillary nerve.
Oh, that makes sense.
So remember that, 5 centimeter.
5 centimeters, got it. So what are we trying to get to with this approach? Why split the deltoid in the first place?
Our target is the supraspinatus and the greater tuberosity.
Okay, so different targets, different approach.
Makes sense, right?
Yeah, totally. So let's move on to a classic,
Oh, you mean
the posterior judate.
the posterior judate.
Yeah. I remember this one being tricky back in anatomy class.
Yeah, it's definitely got a few more steps.
So tell me, what are the danger zones we got to be aware of with this one?
Well, first, you've got the suprascapular nerve,
Okay.
which is hanging out in the suprascapular notch. Always got to watch out for that one.
Right, great.
And then, just to keep things interesting, you've also got the axillary nerve and the posterior circumflex artery.
Wait, so both of those are...
Both together in the quadrangular space.
Oh, like a little party back there.
Exactly. A party you don't want to crash.
So how do we avoid hitting those nerves in that artery?
Okay, so first we position the patient laterally.
Go on.
Gives us the best access. And then the incision follows along the scapular spine, but then it curves inferiorly and medially.
Why the curve?
That curve allows us to detach the deltoid without putting those nerves and the artery at risk.
Clever. So the deltoid's out of the way, then what?
Then we can see the infraspinatus and the teres minor muscles.
Okay, so those are our landmarks now.
Exactly. They guide us right to the joint capsule. Now, we have to be really careful with the retraction here. We retract the teres minor inferiorly, and that moves the quadrangular and triangular spaces out of the way. That keeps the axillary nerve and the posterior circumflex artery safe and sound.
Okay, so it's like a delicate dance.
That's a good way to put it.
All right, I think I'm starting to get this. Now let's switch gears a little bit and talk about something that's become really popular these days, shoulder arthroscopy.
Ah, yes, arthroscopy. It's become the go-to for so many shoulder problems.
So what are the essentials when it comes to positioning for arthroscopy?
Well, we usually use the beach chair position, just like with the open delta pectoral approach.
Okay.
Gives us a good view of the joint.
Okay, so anything we should be extra careful about with the positioning.
Yeah, we have to make sure to pad everything really well, especially around the face.
Right, because their head is tilted back.
Exactly. And we always incline the table slowly, just to avoid any sudden drops in blood pressure.
Safety first. Always good advice. Now, everyone always talks about portals in arthroscopy. Can you break down the portal placement for us?
Sure, so the posterior portal is our main one.
Okay.
It's about 2 centimeters inferior and medial to the posterior corner of the acromion. And you want to aim it towards the coracoid process.
All right, and what plane are we in here?
We're working in the infraspinatus plane.
Okay, posterior portal check. What about the anterior portal?
That one goes just above the subscapularis in the rotator interval.
Why the rotator interval?
Because that gives us access to the joint capsule without having to detach any tendons.
Oh, that's smart.
Yeah, it's a nice little natural opening.
All right, so we've got our portals in place. We're looking inside the shoulder. What layers do we see?
Okay, let's see if you remember your anatomy.
Oh, no, you're going to quiz me.
Always. So first, you have your skin and subcutaneous tissue,
Let's see.
then the deltoid muscle,
Okay.
followed by the subdeltoid bursa,
Got it.
then the infraspinatus muscle,
Uh-huh.
and finally, the joint capsule.
Nailed it.
See, you know your stuff.
Well, I've been studying. Arthroscopy is pretty amazing, isn't it? All that through tiny little incisions.
It really is. It's revolutionized the way we treat shoulder problems.
Patients must be happy about that.
They are. Less pain, quicker recovery. Who wouldn't be happy about that?
Okay, we've covered 4 approaches now. Let's wrap things up with the clavicle anterior approach.
All right, last but not least. So for this one, we position the patient supine,
Okay.
and we put a sandbag between their scapula and their spine.
Why the sandbag?
That helps to stabilize the scapula.
Oh, that makes sense.
The incision follows the subcutaneous border of the clavicle.
So pretty straightforward incision.
Yeah, pretty much.
But I bet the dissection is still tricky.
You bet. So as you go through the layers, you'll come across the platysma muscle.
Okay.
Now, here's the key. You have to preserve those supraclavicular nerves.
Why are they so important? What happens if we hit one?
Well, those nerves provide sensation to the skin over the shoulder and the upper chest.
Yeah.
So if you damage them, the patient could end up with numbness or tingling in that area.
Not ideal.
Not ideal at all.
All right, so that's the clavicle anterior approach. Remember, all of this information comes from the OrthoMade Simple Notes over at mokyingren.sg.
Great resource for anyone studying for their orthopedic exams.
All right, welcome back to the deep dive. We've been talking all about shoulder approaches, but this time we're going to go a little bit further, talk about some of the really cool stuff that's happening in shoulder surgery these days. You know, the stuff that will really impress those examiners.
Yeah, shoulder surgery is a fast-moving field. What was cutting edge a few years ago is practically routine now.
So what are some of the big things that have caught your eye? What's everyone buzzing about?
Well, patient-specific instrumentation is a big one.
Okay, what's that?
We're talking about 3D printing, computer modeling, using that to create custom guides, implants, all tailored to the patient's exact anatomy.
So it's like creating a perfect blueprint for each patient's shoulder.
Exactly. It's all about precision, personalization. You get more accurate placement, less time in the OR, and better results for the patient.
I could see how that would be a game changer, especially for those really complex cases.
Absolutely. We can do things now that we wouldn't have even dreamed of a few years ago.
Amazing.
Yeah.
It's like something out of a sci-fi movie.
It really is. And it's not just 3D printing. We're also seeing a lot of progress with biologics.
Biologics, what are those?
Things like stem cells, platelet-rich plasma, using those to help the body heal faster, regenerate tissue.
So it's not just about fixing the mechanical problem, it's about helping the body heal itself.
Exactly. It's still early days, but I think biologics have huge potential.
It's exciting stuff. And what about robotics? I keep hearing about robotic surgery. How does that work with shoulder surgery?
Well, the robot is like an extension of the surgeon's hands. Gives you better precision, better control, better visualization.
So it's like having a super steady hand, no shaking.
Yeah, pretty much. It's great for minimally invasive procedures, smaller incisions, less tissue damage, which means faster recovery for the patient.
Sounds impressive.
Yeah.
But I have to ask, what if the robot makes a mistake?
That's a common question. But don't worry, the surgeon is always in control. The robot is just a tool. Think of it as a partnership between the surgeon and the technology.
Okay, that makes sense. So it's all about using technology to help surgeons do their best work.
Exactly. And it's not just during the surgery. These robotic systems often have really advanced imaging capabilities. You get real-time feedback during the surgery so you can make adjustments as you go, make sure everything is perfect.
It sounds like the future of shoulder surgery is pretty amazing.
It really is. But remember, technology is just one part of it. You still need a strong foundation in anatomy, biomechanics, surgical principles.
Those are the basics, right? Those never go out of style.
Right. So for all you future surgeons out there, keep learning, stay curious, stay on top of the latest developments. The future of shoulder surgery is in your hands.
Well said. Well, this has been a fascinating deep dive into shoulder approaches.
We covered a lot of ground.
We went from the classic approaches all the way to the cutting edge. And hopefully this has helped you as you prepare for those tough exams.
And remember, a lot of this information is from the OrthoMade Simple Notes, mokyingren.sg. Definitely check it out.
Great resource. Thanks for joining us today, and best of luck on your exams.
See you next time.